Welcome everyone to today's webinar, Riding the Ambulatory Surgery Wave, Increasing Surgical Volume While Cases Leave the Hospital OR. I am Emma Goodman with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have by typing them into the control panel in the space labeled Q&A and clicking send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it's now my pleasure to start today's webinar by introducing our presenter, Jeff Peters. As CEO of Surgical Directions, Jeff has led the operational, clinical, and financial improvement of over 300 hospitals across the country. Jeff is a healthcare strategist with more than 25 years of experience collaborating with physicians and hospital executives. Leading teams of specialists, Jeff has established a consistent track record of enhancing healthcare service delivery through the optimization of workforce, strategy, performance, and supply chain. Jeff is an expert in addressing the operational, financial, and organizational issues within hospital systems. From rural community hospitals to large academic medical centers, he has worked with hundreds of surgical and procedural departments, and he understands the complexities and importance of these services to an organization's financial performance and reputation. Jeff is a national speaker, and he has published numerous articles on anesthesia support and negotiations, OR operations, perioperative benchmarks, block scheduling, physician and hospital relations, and hospital organizational issues. He's a leader in healthcare consulting, sought out by healthcare organizations looking to transform services delivery, improve patient outcomes, control costs, and ultimately achieve a sustainable competitive advantage in their markets. Jeff, it's now my pleasure to turn the floor over to you to begin today's webinar.
Thanks, Emma. It's really a pleasure to be able to talk about ambulatory services and how we can help drive volume within both hospitals and ambulatory networks. So if we could have the first slide, that'd be great. What our objectives are today is to really give you some ideas and tools you can apply to your ambulatory surgery strategy today and immediately begin to focus on the future. What we're going to spend some time talking about are what are the best surgical specialties to focus on in terms of ambulatory growth and what are the key strategies that could make a hospital's perioperative service line more successful or a freestanding surgery center more successful. So welcome the questions, and as we're going through it, just enter it, and we'll try to take as many questions as we possibly can at the end. Next, please. So if you look at the overall market of all procedures done, both within a healthcare setting and a physician's offices, about 80% of all surgeries are now being done on an ambulatory basis. A lot of those in physicians' offices, a lot of those in freestanding ambulatory settings, and a lot in hospitals. And the growth in ambulatory surgery is really being driven by technology, and a little later we'll talk about some of the advances that are coming down the road that will dramatically change how we treat certain cancers and other common inpatient procedures, improvements in pain management and payer pressures. So if you think of surgery today in America, it's really an ambulatory business, with only 20% of all surgeries requiring the patient to stay overnight. So it's not like, how do we grow the ambulatory business? The ambulatory business is really where surgery is today. Next, please. And there's a wide range of procedures There's always been a concentration of ENT, ophthalmology, gastroenterology, multiskeletal nerve treatments, and plastics, but it's changing, and this base is always going to be there. It's going to continue to grow, but just the range and procedures within the specialty are really changing pretty rapidly. Next. And there's also a change in what allows an ambulatory surgery center to sustain as a competitive advantage. 20 years ago, you could have an ambulatory surgery center, get your surgeons enticed by having joint venture opportunities or having the right technology. But increasingly, the ambulatory surgery centers that are going to be successful in the future not only have a depth of specialty expertise, but they're creating the environment to both diagnose and manage the disease. So success requires in having a depth of subspecialty expertise and technology, diagnostic capabilities, which increasingly are required to do the surgery. It says access to capacity. It should be access to capital because it's very expensive, and not just doing the procedure, but providing value. If we could have the next slide, where clinical outcomes are looked at over cost so that we're adding value to the payors. And this is just a really good analysis to sort of look at how the market's changing. Inpatient procedures continue to decline at about a 2% growth rate every 5 years. Over those 5 years, you would typically see outpatient volume growing at 15%. And you can see between last year, 2018, and 2022, most forecasters indicate an 11% growth in ambulatory surgery. A good illustration is orthospine, where we see inpatient procedures dropping over this period of time, outpatient procedures growing. Some of the largest areas of growth are ortho, spine, and GI. So next, please. And growth really comes from broadening the procedures, as we've talked about, broadening the technology and adding value. Orthospine is a classic example. 5 years ago, almost all spine surgery was done on an inpatient basis, really invasive, requiring a lot of pain control and a hospital stay of a couple of days. Now, what we're seeing is technology where rather than removing the disc, or that what they're doing is some very, very fine sort of thinning of the material and taking pressure out of the spinal cord. But to do it, you've got to have a sophisticated diagnosis and treatment plan. You've got to combine rehabilitation with the procedure. And the reason it's growing is that payers have discovered that 50% of all spine procedures are not successful. So what they're looking at is what's the procedure that's going to have the best clinical outcome, the highest improvement in patient satisfaction at the lowest cost. And if we're going to succeed in this ambulatory environment, we have to pay attention to those three factors: outcome, patient engagement or satisfaction, and cost. Next one. And that's increasingly where we're going. So what are some opportunities for hospitals? A major opportunity are some of the existing ASCs that are out there, where the original surgeons are maturing in their practice because more and more surgeons are employed by hospitals or health systems and not really interested in making investments in ASCs, because in order to stay sort of at cutting edge, ASCs now need major capital investment in high-cost technology such as MRI equipment, very sophisticated lasers. One of the opportunities for hospitals is to approach ASCs in the marketplace and say, you know, we would really be interested in acquiring this, and we not only want to acquire the surgery center, but we're happy to employ the surgeons that work there, and it allows hospitals to have ready access to a market where there's an ongoing sort of volume or capacity that they can capture with that investment. So taking advantage of where the market is, but rather than just competing, acquiring. Next. And there's a couple of areas that are emerging that are really prime for hospitals to focus on. We talked a little bit about spine because of the changes in reimbursement and improvements in pain management. Joints are increasingly being done on an ambulatory basis. And I'd like to sort of also talk about a story of what's emerging in urology. So if we could sort of go to the next slide, talk about it. What we've done here is really to try to identify some of the major areas of ambulatory surgery. We've done a very in-depth analysis in terms of most markets where the demand is going to be greatest and what's the margin. And the obvious one is sports medicine. I think most ambulatory settings are doing it. There's high demand. There's a fairly good payer mix because it's typically a younger patient. Increasingly, we're seeing what's being done in terms of gynecology on an ambulatory basis. But if you see the ones that are really, really emerging is neurosurgery, which a couple of years ago, nobody would ever imagine doing neurosurgery or spine surgery on an ambulatory basis. But that's clearly where that specialty is moving. Next slide, please. And what's also important is not only to look at sort of where the growth is, but where and how hospital systems should sort of put their blueprint of where they want to do surgery. And if you look at most hospitals, the decision or question is, do we build a hospital-based outpatient center, which is on the hospital's campus, or within the distance that it can be included within a hospital's reimbursement? So it's reimbursed in an HOPD. That reimbursement is about 45% more than a freestanding ASC. So the question that most hospitals are faced with is, what is more important, us to put a center away from the hospital to capture a market and to get new volume, or is it more important to put our ambulatory resources on our campus where we have an increase in our reimbursement? And that's the trade-off as any strategist for a hospital you need to look at. Next slide. Again, it's totally focused on value. I was at a large health system in the Midwest this week that were looking at what their overall ambulatory surgery strategy was, and was privileged to have a discussion with their board in the sense of, we represent business. We're really paying for the health care provided within the system. And because we're taking our sort of business dollars to provide needed healthcare services to our employees, what we need you to prove is that you're getting better outcomes for your patients, our employees, at a lower cost than anyone else in the market. And we want you to prove that to us on an ongoing basis. So increasingly, it's that value-based payment, and there's rewards. So if you look at bundled payment now, it's shifting to an ambulatory setting. It's totally focused on getting the best outcomes with the lowest cost. And by doing that, the hospital's rewarded, the surgeon's rewarded, because you can share that cost savings as long as the outcomes are better with your surgeons, anesthesiologists, and other providers. And that's key to the success, not volume, but volume that provides value. Next. And that's where commercial insurance is going. What they don't want to do is to pay the hospital, pay the surgeon, pay the anesthesiologist, and pay the SNF. What they've found is if they've got a single entity that manages the entire perspective of care, they're getting better outcomes for their patients at a lower cost. So increasingly, if you talk to the Blues or United, what they're viewing is over the next 3 to 5 years, we're only going to pay for surgery in bundles. We're going to pay for bundles for ambulatory surgery, and the providers that are going to capture this market are ones that understand how to manage this bundle. Next slide, please. And as most of us know, bundled payment really focuses on the entire episode of care. There's going to be one payment for all of the work that's preoperative from the moment the patient is scheduled to the point of surgery, that pre-surgical testing, optimizing a patient's chronic conditions so that they're going to have a good outcome. That's making sure the diabetic's blood sugar level is controlled. That's making sure if a patient has anemia, that's under control before you make the first incision. Looking at the surgical episode and paying for everything within that episode, the facility costs, the supplies, the surgeon, the anesthesiologist, and the pathologist. In terms of post-operative, making sure the patient is in the right setting for their level of care. If a patient's in ASA 1, 2, or 3, an ambulatory setting, whether it be freestanding or within the hospital, normally is fine. If it's a patient with more chronic illnesses, a diabetic, somebody who's had cardiac problems, maybe that patient has to come to the hospital and have a short stay after their surgery, but increasingly focusing on the long-term recovery. 40% of most surgical costs are incurred after the patient leaves the facility. So for joints, you want to make sure that patient goes home instead of going to a long-term care facility or SNF. But in order to go home, you need to make sure that the patient has support at home to recover and has the necessary rehab if they've had some orthopedic or spine procedure, that they can assume activities of normal living. The major reason that United Healthcare found out that patients were admitted to a hospital or readmitted to a hospital after surgery was there wasn't food in the refrigerator. The patient had the surgery and did fine, was on the road to recovery, but didn't have the nutrition at home to live. So increasingly, with complex procedures, those are the types of things we need to pay attention to. Next slide. We not only have to provide the care, but we've got to provide information. This is sort of a dashboard that an East Coast hospital was using for joints. And increasingly, by provider, what we want to have is benchmarks for mortality. We want to have benchmarks for admissions or readmissions. If you're an ambulatory patient and you're discharged to home, do you stay at home, or was there a problem where you had to come back to the hospital? Are there complications by surgical site infections? What's the cost? How that varies between the provider, and increasingly, because our reimbursement also depends upon patient engagement or patient satisfaction, you can see the difference. So clearly, there were some problems in provider B, a much higher sort of complication rate, much higher cost. It's not only providing the care, looking at the benchmarks and saying, you're not meeting the value care benchmarks, you're not getting as good as outcomes, your costs are higher. Let's talk about what's causing that. So you've got to provide the information, you've got to have a physician looking at the information, and a physician having those crucial conversations with any provider that's not meeting the established benchmarks. Next one. So I think I referred to this a little earlier, and it was a journey that I actually went through 14 months ago. I've known for a couple of years I had prostate cancer, but it was a low-grade prostate cancer, not really increasing or metastasizing, but about 14 months ago, there's a dramatic rise in my PSA. I had some MRI exams and biopsies, and I got that call every man sort of hates from his urologist. Hey, Jeff, you know, I've looked at the results of your biopsy, and I'm not comfortable with what's going on with your cancer. We've got to do something about it, and you don't have options. So the point of just observing what was going on with my cancer wasn't an option, according to my surgeon. And of course, I'm neurotic, so I got 3 outside opinions all over the country, and the sort of recommended treatment was either a radical prostatectomy, which is about a 2 to 3 day inpatient stay and a pretty invasive procedure with lots of complications, or radiation, which has 100% complication rate. And I just decided as an active male that wasn't acceptable for me. I wasn't willing to sort of have the risk of those complications, and had a discussion with my surgeon saying, I'm not going to have surgery, I'm not going to have radiation. And his response was, Jeff, well, have you ever seen somebody die of prostate cancer? And my response, and my surgeon really was a friend, I said, Rob, you know, if you were the patient, I was the doctor, I don't think that would be the line of logic that I would use, but clearly got him to understand I wasn't going to do the traditional treatment. And he thought about it for a couple of days and called me back and said, Jeff, there's a new FDA-approved procedure. It's called high-intensity focused ultrasound. I've never recommended this for any patient in the past, but given the fact that your lesion is fairly contained, I think this might be an opportunity for you. And we talked about the benefits, and then I went to both MD Anderson and Roswell Park and got a second opinion, and they all agreed that I would be a good candidate for it. And let's go to the next slide. So, and I think the reason I'm mentioning it is not to talk about what my successful journey was, but to really talk about how the way we're managing illnesses is changing. So it's a Medicare reimbursed procedure, but there's complications in getting paid. So most centers doing HIFU now are requiring the facility fee, the surgeon fee, and the anesthesiology fee up front. It has much less than a 1% chance of any complication. And what they basically do is use the MRI to guide an ultrasound that focuses on the lesion and with heat destroys the lesion. It's about a 90 to 120 minute procedure because the patient has to be still. They get general anesthesia, but a patient feels great and is able to go home in 2 hours. Next slide. It's also a fairly profitable procedure. The procedure depends upon your payer mix. Most centers now have the patients pay up front as they're dealing with insurance and Medicare. I am covered by Blue Cross of Florida, and after a couple of letters justifying the procedure and the benefit of the procedure for me, Blue Cross of Florida did pay all of the facility fees minus the deductible. Medicare also pays for it, and they're looking at adjusting their fees in order to make it much more attractive for patients to have it done. But I think, next slide, the advantage of this procedure is the fact that it's not only profitable, but it's an example of how illnesses that in the past required an inpatient surgical intervention, because of advances in technology, it's able to be done on an ambulatory basis. And the rate or number of robotic prostatectomies within this country over the next 3 to 5 years is expected to drop as insurance coverage expands for it, and increasingly because patients are just satisfied. So I've had it 14 months ago, I'm cancer-free, and I have absolutely no complications. I'm able to do everything that I did before surgery now, and I couldn't be happier. I went to a surgeon who's done about 1,000 of these procedures, and I thought I had great care and just zero complications. So again, it's not so much my journey, but how it represents how technology is expanding the number of procedures we're going to be doing on an ambulatory basis in the U.S. This is in Germany. This has been done for the last 20 years, or in France. Let's go on, please. As we've talked about, it's really an alternative to inpatient surgery. It's emerging technology, and increasingly, it's really this integration of a surgical procedure and high-tech technology. That's the reason why you really increasingly want an ambulatory surgery center to be a component of a comprehensive ambulatory facility with diagnostic facilities, surgeon offices, the surgical suites and probably rehab. That's what's going to allow you to treat the new procedures being done on an ambulatory basis. That's what's going to give you a competitive advantage in this increasingly complex market. Let's go on. But it's not just providing the facilities. There's got to be an overall different way of sort of managing that ambulatory enterprise. What it really requires is a governance body that brings physician leadership, hospital leadership, or center leadership, the surgeons, the anesthesiologists together, looking at what is the direction we're going to go, what resources are required to do it, and what information do we need to make sure we're delivering the care we want. It also requires, and we're going to spend some more time talking about it, a clinical redesign, really looking differently how we prepare patients for surgery, how we prepare our resources prior to surgery, and how we watch the recovery. And what it also requires is engagement, because patients want to know what is going on with them. And if they have questions, they want instantaneous answer to their questions. So let's delve into these concepts of how you manage an ambulatory setting optimally. If we could have the next slide. The first thing to realize is every sort of administrator, every nurse that works in an ambulatory setting needs to be totally passionate and engaged that they're going to take the best care of their patient. Constantly thinking about what do we need to make sure something doesn't go wrong and that patient has to be admitted to the hospital. What can we do to make sure that patient has no pain and is comfortable in their recovery, while at the same time not giving them opiates or anything that would impede their long-term success? What do we need to do to optimize that patient to make sure there's no postoperative nausea and that you should be vomiting? And that increasingly is using ERAS protocols so the patient is not nutritionally deprived prior to surgery. We want most of our patients to be drinking clear liquids up to 2 hours prior to surgery so that we know their functional status is good. From the moment they check in, that first contact at the registration desk has to convey a communication about the fact that we're glad you're here, and I just want you to know that we're going to take good care of you, and that you're going to have the best surgical outcome because of the resources you've come to that you could get anywhere. They want to be engaged. They want to understand the anesthesia process. They want people to explain what's going on, and you want to understand what you need to do after surgery, prior to surgery, where you're fully oriented and not recovering and sort of getting out from anesthesia. We want to make sure that if it's complex postoperative instructions that they're given prior to surgery, we're reminded of them before that first narcotic goes into the IV, and that you've got an advocate and you can communicate with us not only while you're here, but while you're at home and have questions. This idea of just checking on a patient with a care call 24 hours after surgery it's not enough anymore to keep that patient engaged. So let's go to the next slide. Here is an example of data on morbidity, mortality, complications. Again, part of what the governance body needs to do is to come together and establish dashboards that look at, and this is for joints, what is our benchmark for outcomes and how does each provider compare? And what we want to make sure is that we have these dashboards and they're not just looked at by the center or the chief medical officer, but every provider every month gets an example of how they're performing against the benchmark, how their complications compare with other providers operating at the same facility and having approximately the same patients with the same risk factors. Data is what drives performance, and just by comparing providers to other providers over time, that's going to result in a higher level of performance. Next slide. And we need to focus on how we optimize the clinical performance, and we're going to talk a little bit about pre-surgical optimization, how a daily huddle benefits it, and how ERAS, advanced recovery after surgery, helps. So let's delve into these a little bit more with the next slide. What's really key is looking at the entire perspective of care and sitting down, whether it's a joint procedure or it's a prostatectomy, and saying, what do we need to do before the patient gets to the facility to make sure we're optimizing performance? And then looking at not only what goes on in the facility, but what goes on after they're discharged, not just with the surgeon following up, but most of the complications from surgery are not from the procedure. It's that the diabetic had trouble managing their insulin levels after surgery, or patients got confused as to what hypertensives they should take. We need to make sure that the primary care is coordinated, and if we're going to have major changes, that patient is checking in with the primary care after surgery, because that is what contributes to problems. If they're having a knee or a neuro procedure and they're going home, we want to arrange home care. We want to make sure their refrigerator has food for them, and we want to make sure they're getting that outpatient therapy at home so that we're continuing to improve their activities of daily function and making sure folks are mobile. Next one. And where it starts is this pre-surgical optimization. For most ambulatory settings, a phone call makes total sense. Just looking at what the patient's baseline healthcare status is, what meds they're on, educating them what they should do prior to surgery, what they should do after surgery. If it's a more complicated procedure, such as a knee or hip replacement that's being done on an ambulatory basis, there's a real benefit in having that patient come in prior to surgery so they could be talked about what's going to go on during your surgery. You're going to be able to walk and ambulate within 2 hours after surgery in the post-anesthesia care unit. We're going to send you home, and these are the activities we're going to expect you to do in that first day home, in the second day home, really helping them to understand sort of the entire course of that treatment. Patients want to know what's going to happen. They want to know what problems they can anticipate, and more importantly, if they do have a problem or a question, how do they get support so they're not worried that something is going wrong? That's what the pre-surgical optimization's involved with a simple ENT procedure, a simple gynae procedure. It's a phone call. If you're having more complicated procedures like I had with HIFU, there's a lot going on after your discharge. You have a catheter, how you manage that catheter, what do you do if there's a problem, when can that catheter come out, who do you go see to get that catheter out, or can you do it yourself? And if you do it yourself, here's how you do it. That's all part of what the education needs to go through in terms of pre-surgical optimization, increasingly as we have more complicated procedures being done on an ambulatory basis. And let's go to the next slide and go into this a little further. What is really key is patient engagement. For complex procedures like spine procedures and knee and hip replacement, what patients want to have is an attachment to their facility. So we can give them apps that allows them to communicate with their surgeon and get answers quickly. If they've got a question about their wound, they take a picture of it, send it to the surgeon, and they're worried that it's red. The surgeon goes, nope, that's fine. What they also do is there's the ability each day to go through a different educational module. Here's the exercises we want you to do today. Here's how you go about doing it. What patient engagements and apps allow you to do is to have communication between the provider and the patient, and it does tremendous things in terms of helping to increase their function and to removing their anxiety. You don't have to worry about what's going on with your patients. You can communicate, and surgeons are increasingly sort of very comfortable using this to stay engaged. They like it. I went to a speech from a colorectal surgeon who had established such a good relationship with a young high school student that he did a procedure on that. She sent him a picture of her with her boyfriend at going to homecoming, and he liked it. That's not the relationship that you're going to have with all your patients, but you can for those patients that need it or you feel comfortable sort of staying connected with. Can we hit the next one? So as you're looking at your overall ambulatory strategy, there's a couple of critical questions that you as a facility need to ask yourself as you develop your new strategy or look at whether we've got the right strategy going forward. The first one is what services will give our facility a competitive advantage. Is it enough to just provide an ambulatory surgery setting, or do we need to include it in a more comprehensive ambulatory setting where we can look at diagnostics and treatment? As you know, I'm fairly biased. I think what we want to do is not only do the procedure, but manage that disease overall. So I think you really increasingly want to have your surgery or your ambulatory surgery setting in a more comprehensive facility. We've talked about what the demand and what the margin is for various procedures. It does help to have a depth of procedures and a cluster of surgeons So if you're developing a new center or looking to expand it, really talking to surgeons about what volume they would bring to your facility, but more importantly, asking the question about what are your needs, what really frustrates you about where you're doing your surgery now. Do you always start your procedure on time? Is the staff trained so that it's done quickly and efficiently? Do you feel welcomed by the staff? Really asking that surgeon, what can we do to make it a better experience, both for you as the surgeon and your patient? Because we don't just want to know what we're doing well, it's talking about what we can improve upon. Increasingly, if you as an ASC are willing to accept bundled payment for procedures, particularly complicated procedures, the joint replacements, the spine procedures, the urological procedures that we've talked about, the payors are willing to allow the ASC to be the bundler and to establish what payment is made to the surgeon, to the anesthesiologist, to the pathologist, and the facility. And that if there is excess funds after you pay the normal fees, and if you have less complications and better results, you're increasingly allowed to share those benefits with the providers who are delivering that care. That's not fee splitting. It's based upon enhancing clinical outcomes at lower costs. And in many cases, that's what's going to give you a competitive advantage. If you're willing to work with the payers to go to bundled payment, they're going to direct more patients to you, which allows you to have a more robust facility with more margin. You've got to ask the question, how do we handle patient responsibility? Increasingly with high deductibles, co-insurance plan, not only laying out clinically what's expected of the patient, but patients don't want a surprise. They don't want to get a bill 30 days after surgery and see, I didn't realize I'm paying my anesthesiologist $1,300. I thought that was covered by my insurance. So we need to not only manage the patient's expectations clinically, we need to manage the patient's expectation financially. But if you put these packages together of diagnostics, of being able to coordinate care, providing a higher level of service, what you as an ASC are going to be able to do is take these more complex procedures where there's a higher margin and a more sort of satisfactory, clinically patient base that keeps the staff motivated, that I'm not just coming to work and as a factory, but I'm really helping to manage patients' problems. You're going to have a more stable staff. You're going to have a more financially attractive facility, and that's going to drive your viability. But as we increasingly manage these more complex staff, it requires more capital. You can't do it with just having a surgical nurse that gets a day of orientation. We've got to work with our staff as to what are the clinical pathways, what are the clinical processes we need to change, what do we need to do to make sure we're providing the care that we want. So it takes a lot more education, a lot more resources, but what we found is the organizations that are moving beyond the simple ambulatory procedures to the more complex ambulatory procedures are getting a financial return. but you've got to evaluate whether that capital investment is worth it and whether you have the clinical, financial, data, and organizational skills to sort of manage this new population. But that's clearly where the growth opportunity is in surgery. So Emma, those are really my prepared remarks, and I'm just wondering if anybody who's listened in might have some questions.
Yes, thank you so much, Jeff, for that fantastic presentation as well as sharing your story. We'll begin today's question and answer session. You can submit any questions you have by typing them into your control panel in the space labeled Enter a Question and clicking Send. We'll try to get through as many questions as we have time for, and we already have a few questions coming in from the audience that we'll get started on. So Jeff, the first question here is, we just heard our gastroenterologists are thinking of opening an endo center, but we have not had a good relationship with this group historically. What advice do you have for them on what they should do in next steps?
So that's a fairly common problem amongst hospitals and healthcare providers. Most endoscopies are done on an ambulatory basis. There's relatively good reimbursement and a very low or no coinsurance or deductibles. So what gastroenterologists are thinking is, why should I just get my professional fee? I can get the facility fee. I can have an anesthesiologist and share in that. So usually there's a financial incentive for gastroenterologists to build their own center. In many cases, it's convenient. It's attached to their offices, and they can see patients in the morning and walk down the hall and do endoscopies in the afternoon. The unfortunate part is they're still going to use the hospital for their GI bleeds, the complicated patient where the reimbursement isn't high as high. So the first and most important thing is to establish communication, to look and talk to the gastroenterologist. What's motivating you to do it? Is there a problem getting your patients on the schedule? Do you think we're efficient and are meeting your needs, or is there lack of efficiency? So try to see if there's anything you can do to improve the service needs at the hospital. Typically, that's not enough. They're motivated financially to do it. So one of the thoughts is, if they're going to do it, whether it makes sense for you to be a joint venture partner in it. And many times it's better to get half of a facility cost than no facility cost, or half the profit, so that you could be a joint venture partner with them. And what the attraction of that sometimes is you're going to help provide the capital, but more importantly, should they decide to retire or unwind the facility, is that you would then give them the ability to sell their shares back to the health system or hospital. And in many cases, having that safety net, having that financial partner goes a long way to sort of just losing that entire service line to potentially sharing in the revenue. So I hope those thoughts were helpful.
Absolutely.
Sharon?
Thank you for providing those best practices and next steps. We have another question from an audience member who has said that their outpatient surgery margin is dropping. What service lines should they explore to try and help their margins? So
I think, during the presentation, we talked about a number of those, and I don't want to repeat it. You can certainly, Emma will send you the slides in doing it. But another opportunity that a lot of ambulatory surgery centers have done is they've included a pain practice within their ambulatory surgery setting, where it's a comprehensive practice that you're looking at patients with acute pain or chronic pain. They're seeing a physician or advanced practice provider to evaluate them, to look at treatment options, physical therapy. But one of the most profitable procedures done in an ambulatory setting is the epidural injections, the blocks, and other treatments in terms of what a provider can do to manage pain. They're typically very quick procedures between the patient getting in, positioned, and out. In many cases is less than 15 minutes. It has very, very good reimbursement for them. So in addition to the surgical procedures, incorporating pain makes a lot of sense, particularly because there's anesthesiologists that are interested in pain management. And as the OR volume sort of declines during the day, it allows the anesthesiologist still to be there to provide care to patients recovering, but it's generating revenue for the facility when the ORs are shutting down. So I would look at pain. It's typically got margins that exceed 40% of net revenue. Is there one more question, I think?
Yes, it looks like we do have time for one more question here. And this audience member has said that they own a joint venture ASC with 16 surgeons. The center is over 26 years old, and the original surgeons are talking about retirement plans. What strategies do you think that they should explore there?
So this is pretty common, particularly the surgery centers that were built in the past. I think increasingly young surgeons are employed, and they're not going to want to invest in the facility. So this is a wonderful opportunity to talk to the surgeons about buying out their ownership, employing them as part of the practice, helping to transition their practice to younger surgeons, and having some of the younger employed surgeons not just operate on the hospital campus in the facility, but really helping them to sort of practice in the outlying areas where it's important that the hospital sort of continue to maintain its market share and grow it. So you're transitioning the surgeons' practices to younger surgeons that are employed, yet at the same time, you're sort of maintaining that ongoing surgery center as a source of clinical care for your patients. So I think we're out of time, Emma. I can't thank you enough for giving us the opportunity to share some of our thoughts with you.
Yes, thank you so much, Jeff. And we'd also like to thank Surgical Directions for their presentation and to our audience for participating today. We hope you enjoy the rest of your day, and we look forward to having you join us for future webinars.